I'm Dr. Aparna Sudhakar, Assistant Professor from the Department of General Medicine. Today we will be discussing about tetanus. These are the subtopics that we will be discussing today. To begin with, tetanus derives its word from the Greek word tetanus, which means taut. It is a severe disease with high mortality rate. It is associated with skeletal muscle spasm and autonomic nervous disturbances. The bacterium Clostridium tetani produces a powerful neurotoxin which is responsible for this spasticity. It is also completely preventable by vaccination. So one of the vaccine preventable deadly diseases, and it usually occurs in areas where the vaccine coverage is low. Now, tetanus is defined based on clinical grounds. The Center for Disease Control and Prevention defines tetanus as an acute illness with muscle spasms or hypertonia in the absence of a more likely diagnosis. So patient can have body spasms that can be locked jaw or inability to open the mouth completely. There will be difficulty in swallowing and some autonomic disturbances which can cause hypertension, hypotension, tachycardia, bradycardia. Now, neonatal tetanus is defined by WHO as an illness occurring in a child who has the normal ability to suck and cry in the first 2 days of life, but loses this ability between days 3 and 28 of life and becomes rigid and has spasms. Maternal tetanus is defined by WHO as tetanus occurring during pregnancy or within 6 weeks after the conclusion of pregnancy. It is a rare disease in the developed world due to high vaccine coverage. The high-risk groups include people who are more than 65 years, who are incompletely vaccinated or non-vaccinated, those who practice skin injections such as injecting heroin subcutaneously. Now, India achieved elimination of maternal and neonatal tetanus in April 2015. Elimination is defined as having less than 1 case per 1,000 live births in every district in the entire country. Now, the number of cases of mortality has declined with the introduction of universal vaccination. Now, let's look into the etiology. Now, Clostridium tetani is a bacilli which is anaerobic, gram-positive, and spore-forming. These spores are highly resistant or resilient and can survive easily in bad environmental conditions. They can resist boiling and many disinfectants. So these spores survive in the intestinal system of many animals, and fecal carriage is also common. And they remain in the soil and they enter the body through abrasions or wounds, or in the case of neonates, through the umbilical stump. These spores, they are resilient, and the organism is a gram-positive anaerobe. The spores that you can see in the ends of the bacilli. Now, whenever the environmental conditions are unfavorable, spores are formed, and these spores survive in the environment for a very long duration of time. Fecal carriage is also common to animals, and these spores enter the body through abrasions or cuts commonly. Now, let's say there is a small injury, and then the tetanus bacilli, which is present in the environment, enters the wound, and then it causes the manifestations of tetanus. In children, due to certain unhygienic practices like putting some mud on or cow dung on the umbilical stump can cause neonatal tetanus. Unhygienic obstetric practices like using unsterilized blade or scalpel can cause the neonatal tetanus. Now, let's say the organism, once the organism enters a suitable host, it causes the organism to multiply, releasing the tetanus toxin, which is a powerful neurotoxin. It causes the disease manifestations. It is very potent even in very small doses in the range of nanograms. But the thing is, even in 20 to 30% of the cases, the puncture entry wound may not be found. Superficial abrasions are the most common causes of contact and spread of the spores. Deeper infections can cause more severe infections, more severe diseases, especially because deeper the infection, more the favorable anaerobic environment for the organism. Now, even procedures like circumcision, ear piercing, when it is done without following strict aseptic precautions, can cause the spread of tetanus. Now, let's look into the pathogenesis. Now, once the organism enters through the wound, now the organism multiplies, the spores causes the organism to multiply. Now, from the organisms, that is from the Clostridium tetani, you have the powerful neurotoxins which is released, and these neurotoxins ascend into the CNS, into the ventral horn cells, and then they cause inhibition of the inhibitory interneurons, which causes excessive action of the excessive firing of the neurons, and that causes the spasms. Let's see, look into it a little more in depth. So the toxin is tetanospasmin, which is the neurotoxin. Now it has a retrograde transport into the central nervous system. It is transported to the ventral horns or into the motor nuclei of the cranial nerves. Now these toxins get bound to the carboxy end of the toxin gets bound to the membrane components of the presynaptic motor nerve terminals, which causes it to be internalized into the nerves. Now this is transported retrogradely and reaches the ventral horn cells or the motor the nuclei of the cranial nerves, and then it causes its manifestation. So let's say it in essence via the into the nuclei, and it causes blockage of the GABAergic inhibitory interneurons. So this causes the interneuron discharge to be blocked, and there is unregulated activity of the motor nervous system as well as the autonomic nervous system, which is responsible for the clinical manifestation. So this is the primary mechanism. Once the neurotoxin inhibits the GABAergic interneurons, that is, release of the inhibitory neurotransmitters is blocked, and then there is overaction of the motor neurons. This is what happens. The nerve, the toxin enters into the nerve, and then it causes a retrograde transport. It goes and blocks the inhibitory interneurons, causing excessive firing of the motor neuron. The toxin is tetanospasmin. So there is overaction of the excitatory neurotransmitter, and there is blockage of the inhibitory interneurons. Now, how does the nerve recover after it is affected with tetanus? So once the tetanospasmin goes and blocks the inhibitory interneuron, how does the nerve again recover? Now, the mechanism is not clearly known. It can even take several weeks. Either the toxin undergoes degradation or there is nerve sprouting. Now, let's look into the clinical features. So, clinical features in the incubation period, which lasts around 7 to 10 days, the patient can initially, after the incubation period, the patient can have vague symptoms like fever, arthralgia, and then the spasms start. Then followed by autonomic nervous system disturbances. Death can follow because of respiratory failure or cardiac arrhythmias. Now, if you look into the classification based on clinical features, it can be localized tetanus or generalized. Localized, let's say, one is cephalic tetanus, where you have muscle spasms involving laryngeal, pharyngeal muscles, which can cause aspiration, airway obstruction. So there is only involvement of isolated areas of the body, most of which can go as a mild form until and unless it's cephalic tetanus, which can cause airway obstruction. Then there is generalized tetanus, which is commonly described, where the muscles of the face and the jaw first affected, and then the rest of the body. So younger the onset, let's say neonatal tetanus, has a worse outcome. Shorter the incubation period, deeper the wound, and earlier the onset of spasms, worse is the prognosis. So again, through the wound, the spores entered. The spores, now since they have a favorable anaerobic environment, the bacilli are formed. From the bacilli, they multiply, release the tetanospasmin. Tetanospasmin enters the neurons, has a retrograde transport, causes the inhibition of the inhibitory neurotransmitter, so that the excitatory neurotransmitter goes unchecked. So there is unchecked firing of the motor neuron. There is spasms, which initially begin with, if it's generalized tetanus, usually begins with the face, the jaw muscles, and it has this characteristic facial feature, which is known as rhizus sardonicus, or a satanic smile, because of the tightness or the tautness of the facial muscles. This can also be associated with autonomic disturbances. So these are the features. So initially, there can be just mild trismus, which generalized spasticity. There is no respiratory compromise when it's moderate grade based on Ablett classification of tetanus severity. Moderate trismus, short spasms, mild dysphagia, moderate respiratory involvement, respiratory rate is higher. Severe, when there is severe trismus, there are prolonged spasms, there is severe dysphagia, apneic spells, the respiratory rate is more than 40. Very severe is with autonomic dysfunction, disturbances. So lockjaw is when the jaw muscles undergo spasm. There is difficulty in opening the mouth, difficulty in swallowing. And opisthotonius is the characteristic arched back posture where there is hyperextension spasticity in which the individual's head, neck, and spinal column enter into a complete bridging or arching position. A facial expression which is characterized by raised eyebrows is known as rhizus sardonicus. So this is rhizus sardonicus, lockjaw, and this is opisthotonius, the posturing. Now, the faster the progression of the illness, the worse the outcome. Children will have difficulty in feeding. Now, the muscle spasms can be very painful. Laryngeal muscles, when they undergo spasm, there can be a respiratory failure, which is the most common cause of death in trismus. So the patients will have to be mechanically ventilated as soon as they have been diagnosed with tetanus before the respiratory muscles, before the laryngeal muscles undergo spasm. You have to immediately intubate the patient, mechanically ventilate the patient because there is a high chance of airway obstruction if we do not mechanically ventilate the patient. There is also associated autonomic instability, which is again one of the most common causes of death, which can cause cardiovascular events. There can be high blood pressure, low blood pressure, tachycardia. There can be gastrointestinal stasis, sweating, increased tracheal secretions, which are very common during the second week of severe tetanus. So this is the flow chart. Initially, there is a wound infection. There is entry of the spores. Then there is multiplication of the organism, which is Clostridium tetani. There is an incubation period of around 7 to 10 days. Now the tetanus toxin, meanwhile, enters, goes and inhibits the GABAergic inhibitory interneuron and starts producing the initial symptoms after the incubation period is over, which begins with fever, arthralgia, muscle aches, trismus, and then the toxin further causes widespread inhibition of the motor and autonomic nervous system. Sorry, this inhibition of the motor and autonomic nervous system. Another few days, it can suddenly progress. Muscle spasms can become generalized. Cardiovascular instability can be there. There can be increased GI secretion. Now, if the patient survives, there is a recovery phase which is associated with the degradation of the toxin or sprouting of new nerve terminals, which can finally cause cessation of the spasms, which can bring back the autonomic control. This might take a duration of a month to 2 months. Now, the symptoms which are summarized: jaw cramping, locked jaw. Then there is opisthotonius, there is dysphagia. Patient will have autonomic disturbances. Now, how do we diagnose? Now, diagnosis is primarily clinical. Now, supportive diagnosis includes culture isolation, which can be negative in 60 to 70% of the cases. The sensitivity is not very high. Now, serum anti-tetanus immunoglobulin can also be measured. The serum bioassay of the tetanus toxin is not usually performed. Differential diagnosis for tetanus includes strychnine poisoning, dystonia due to anticholinergics, hypocalcemia, which can cause a tetany, which resembles tetanus, meningoencephalitis, and trismus due to any oropharyngeal infection. Now, how do we treat? Now, treatment is very, very important. The entry site should be identified, should be cleaned, and debrided of all necrotic material. First of all, we have to remove the focus of anaerobic infection so as to prevent further toxin production. Very, very important is to clean the area, which might seem a very simple measure, but is highly effective in preventing further toxin production and destroying any organism. The antibiotic of choice is metronidazole. For anaerobic coverage, it can be given intravenously as 500 milligrams for 7 days. Administration of tetanus toxoid, or TT as it is popularly called, as soon as you find a wound, which is as soon as you get any wound, which may be abrasion or laceration. Now, certain conditions, which we will be discussing in the subsequent slides, we have to give an antitoxin, which will deactivate any circulated tetanus toxin and prevent it from being taken up into the nervous system, which has to be given early. Now, wound care is of primary importance, utmost importance to clean the area, disinfect the area. Now, tetanus toxoid, administration of TT, very popularly known among people that as soon as you get a wound, you have to get a TT injection. It was developed by Descombe in 1924. It was used in the military during the World War II. It comes as a formulation separately, or it can be given in combination with the diphtheria pertussis vaccine, or separately only with the diphtheria vaccine. Now, under the universal vaccination program, we have 5 shots in childhood, 1 in adolescence, and 1 in 10 years thereafter. So you get the tetanus toxoid vaccination once every 10 years. There is near 100% protection from tetanus. So this is one of the vaccine preventable diseases. The other vaccine preventable include polio, smallpox, etc. This is another deadly disease which can be completely vaccine prevented. So hence the tetanus toxoid has been incorporated much early in the universal vaccination program. There are very few side effects, like local side effects of itching or redness or swelling at the site of injection. So there should not be any inhibition in taking this tetanus toxoid. This is the tetanus toxoid vaccine. It can either come separately or along with the national immunization program. We have it along with diphtheria pertussis vaccination. Now, a word about the tetanus immunoglobulin. Tetanus immunoglobulin, or the antitoxin, it is given as a single intramuscular dose, around 3,000 to 5,000 international units, around the wound, as a single IM injection. This has to be given in certain conditions. This is even intrathecal administration can inhibit disease progression. So now, where do you administer tetanus immunoglobulin, TED-glob as it is popularly known as? Let's say a patient is not immunized or has been immunized with less than 3 doses, even if it's a clean wound, you have to, or a minor wound, you have to give the tetanus vaccine. But you do not have to give TED-glob until and unless the wound is not clean or the wound is a major wound. Now, let's say the patient has been immunized with at least 3 doses. If the patient has sustained a wound which is less than 5 years since the last dose, then there is no need to administer tetanus vaccine or tetanus immunoglobulin, irrespective of whatever the wound may be. Now, let's say it's been around 5 to 10 years since the last dose, then you have to administer only the tetanus toxoid if the wound is unclean. Now, you have to administer the tetanus toxoid irrespective of whether the patient is fully immunized or has not been immunized, if it has been more than 10 years since the last dose. So for a clean wound, as well as for all the other unclean major wounds, which are large contaminated wounds, you have to administer tetanus toxoid, and you give the antitoxin or tetanus immunoglobulin if it is more than 10 years since the complete vaccination in a non-hygienic wound. So tetanus immunoglobulin it is administered only if the wound is large or not a minor wound and it is not clean. So any clean wound, especially if the patient has been fully vaccinated, there is no requirement of giving TED-glob. Only if patient is not completely vaccinated or it has been more than 10 years since the last vaccination, does the patient require tetanus immunoglobulin. It is given intramuscularly along the site of the wound. Now, what happens after the patient has developed the spasms? You have to give heavy sedation, benzodiazepines to control the spasms. Lifestyle relaxant like magnesium sulfate can be used. The patient should be in a calm, quiet environment, just like how you use the same protocol in rabies. because light and noise can trigger the spasms. So because of the autonomic instability, there can be rapid fluctuations in the blood pressure as well as the heart rate, which can be improved by deep sedation or by using appropriate drugs like beta blockers or calcium channel blockers. Now, the primary aim is to secure an early airway in severe tetanus. So before the spasms become too severe to cause laryngeal or airway obstruction, we have to secure an airway in the form of mechanical ventilation, which can be either endotracheal intubation or it can be a tracheostomy. Now, tracheal secretions also are increased because of the autonomic disturbances. There is dysphagia due to the pharyngeal involvement as well as the laryngeal involvement. So if once the involvement of the laryngeal and pharyngeal muscles begin, then it's difficult to do an endotracheal intubation. The tracheostomy is ideal in severe tetanus. So an early tracheostomy should be planned. Now, since the patient will be immobilized, will be heavily sedated, or prophylaxis for deep venous thrombosis should also be given without fail. Early intubation or tracheostomy, patient should be kept in a quiet environment. This is endotracheal intubation, this is a tracheostomy. Now, once the patient is in the ICU with tracheostomy or with mechanical ventilation sedated, there is a possibility of sepsis either in the form of ventilator-associated pneumonia or central and associated pneumonia if you have put a central venous catheter. There is also a possibility of deep venous thrombosis because of prolonged immobilization. This is a picture which demonstrates central and associated bloodstream infection or collapse. So either because of contaminated infusate or contaminated catheter hub or skin organisms because of the health extrinsically through contaminated hands of the healthcare workers or disinfectants, it can enter colonize the catheter and cause catheter-related bloodstream infection. Or there can be a ventilator-associated pneumonia because of prolonged intubation. Now, neonatal tetanus is associated with a poorer prognosis, elderly individuals, a shorter incubation period, shorter time for the first symptom to begin, post-surgery, post-burns, puerperal, all of them have a higher degree of severity. If the patient has already developed autonomic disturbances early on, that also suggests a poorer prognosis. Patient has severe spasms, severe disease, that also has a poorer prognosis. In neonatal tetanus, a younger age, premature birth, shorter incubation period, delay in hospital admission, low birth weight, etc. have poorer prognosis. Now, how does the patient recover from tetanus? Recovery can take a period of almost 1 month to 2 months. This is an average, it can vary. This involves the sprouting of newer nerve terminals or toxin degradation. Recovery is usually complete, and the patient has to be given a full primary course of immunization. Children and neonates have a higher chance of developing neurological sequelae. There is also no herd immunity effect for tetanus, so everybody has to be vaccinated completely. And these are some of the vaccine preventable diseases: COVID, measles, varicella, meningococcus, polio, tetanus, hepatitis, pertussis, influenza, and diphtheria. So what is prevention? Prevention is always better than cure. There should be good wound care as well as immunization following exposure. Use of safe, clean delivery as well as cord care practices is of utmost importance. This is one of the ways by which we achieved the elimination of tetanus. Maternal vaccination is a very also of utmost importance. Now, WHO advises a primary course of 3 doses in infancy, boosters at 4 to 7 years, and then 1 at adolescence, and 1 booster in adults. In the US, additional dose of at 15 to 18 months, and then boosters every 10 years will be given. Tetanus toxoid is in the national immunization program given along with the diphtheria toxoid or the acellular pertussis vaccine. Now, this is the vaccination schedule. At 6 weeks, 10 weeks, 14 weeks, 0.5 ml is given intramuscularly in the anterolateral side of the thigh on the left side. Then you give 1 dose at 1 year of age. This is the pentavalent vaccine, or it can be given as a vaccine along with diphtheria, pertussis, and tetanus. So there are three doses in infancy, then at booster doses, then at around at 4 to 7 years and 12 to 15 years. So till 1 year of age, you can administer this vaccine. The maternal tetanus is tetanus which occurs during pregnancy or within the 6 weeks of termination of pregnancy. Two doses of tetanus toxoid or TT injections given 1 month apart to an unimmunized pregnant woman. Now, vaccination reduces the incidence of neonatal tetanus by almost 94%. Education programs improve hygiene during the birth process, reduces the incidence by 40%. In 1989, the World Health Assembly adopted a resolution to eliminate neonatal tetanus by the year 2000. Elimination was defined as less than one case per 1,000 live births in every district in every country. India achieved the elimination of both maternal and neonatal tetanus in April 2015. Now, so following a trauma, individuals sustaining tetanus-prone wounds should be immunized if their vaccination status is incomplete or unknown, or if their last booster was given more than 10 years earlier. There are non-minor wounds or not contaminated. If there are non-minor wounds or contaminated wounds, tetanus immunoglobulin has to be given if the patient has never been immunized or it's been more than 10 years since the last booster. Clinical features begin after the tetanus toxin has reached the synaptic inhibitory neurons. So during the incubation period, so as early as possible, you have to give the tetanus toxin, the antitoxin. Now, once these effects become apparent, that is, once the neurotoxic effects become apparent, there may be little that can be done to affect the disease progression. Treatment should not be delayed while the results of the laboratory tests are awaited. Management strategies aim to neutralize remaining unbound toxin and support vital functions until the effects of the toxin have worn off. Recent interest has focused on intrathecal methods of antitoxin administration to neutralize the toxin within the CNS and limit the disease progression. Tetanus vaccine, which comes under the National Immunization Program along with diphtheria and pertussis in our country. CDC advises patients in infancy, then at 15 to 18 months, then 4 to 6 years, once every 10 years later, one in adolescence, and then once every 10 years. This is the program by CDC. Thank you all. Well, that sums up the class for today. So we discussed about tetanus, about the etiology, the pathogenesis. The etiology is by Clostridium bacillus, which is a gram-positive spore-forming anaerobic organism which forms spores that are highly resilient. These spores, when they enter through a wound, let's say an abrasion or a laceration or any wound, it can cause proliferation of the bacteria and release of a powerful neurotoxin that is tetanus plasmin. If you look into the pathogenesis, tetanus plasmin enters the neuron, and then it has a retrograde transmission. It enters the ventral horns of the spinal cord or the motor nuclei of the cranial nerve and causes inhibition of the GABAergic inhibitory interneuron. So there is excessive firing of the excitatory neurotransmitters, which causes, as well as in the autonomic nervous system, which causes the spasms. The tetanus derives its name because of the spasms. Tetanus derives its name from the Greek word, which means being taught. Now, the patient develops spasms, autonomic disturbances after the incubation period. So shorter the incubation period, more severe the symptoms. The presence of autonomic instability, more grave is the prognosis. Now, the aim should be prevention as well as good wound hygiene. Now, let's say the patient has already had a wound. Initially, to clean the wound, give them a shot of tetanus toxoid. Now, how do I administer tetanus toxoid? Apart from the national immunization program, if the patient has not received even 3 doses, then full tetanus toxoid has to be given irrespective of whatever be the wound. If the patient has received within the last 10 years, then you have to give it. You do not necessarily have to give it until the wound is non-minor or if it is contaminated. If the patient has had a wound which is after 10 years of getting the entire course of vaccination for at least 3 doses, then you have to give the tetanus toxoid. We administer an antitoxin, which is a tetanus immunoglobulin along with it. If the wound is contaminated or non-minor in a patient who has not completed even 3 doses, or in a patient who's completed 3 doses if it's been more than 10 years since the last dose, then you have to give a tetanus immunoglobulin along with the tetanus toxoid. If the patient starts developing symptoms, then you have to plan for an early ventilation mechanically, either in the form of endotracheal intubation or tracheostomy. Now, the causes for death are usually laryngeal spasms, which causes respiratory compromise, or cardiac arrhythmias due to autonomic instability. Now, by around 4 to 6 weeks, if everything goes well, if the patient does not develop any further complications due to ICU stay, we have to give a DVT prophylaxis. Also, look for any features of ventilator associated pneumonia, bed sores, etc. Give them proper sedation while they're intubated and ventilated mechanically. If the patient does not develop any complications, by around 4 to 6 weeks, there is a chance of recovery, which is in the form of nerve sprouting or toxin degradation. All the spasm starts disappearing. If it is a neonatal case of neural tetanus, there is a possibility of developing neurological sequelae. This vaccination is of utmost importance. Hence, it has been included in the national immunization program. India has achieved elimination of maternal and neonatal tetanus, which is less than 1 case of neonatal tetanus in 1,000 births in every district in the country by April 2015. Thank you all. That will be the discussion for today.